from Paris.
Thank you very much. Thank you for the organizing committee for having invited me to this beautiful place and beautiful Congress. We have no conflict of interest regarding this data. So P53 looks very promising as a tumor biomarker, since you can see on the left panel that P53, this picture has been called the Copernican view of P53. P53 is right at the center of so many pathways in the cell, many pathways that are involved in tumor regulation, tumor proliferation, or tumor suppression. Also, on the right panel, you can see that P53 is very frequently mutated in breast cancer in 20 to 30%. However, despite all this promising data, P53 is not yet used as a biomarker for the management of breast cancer. And in this talk, I want to tell you that maybe this is due to, because P53 is very linked to tumor subtypes, and also I will tell you about tumor response to chemotherapy and some new insights that appeared these last few months. P53 is a transcription factor that is regulated by stress. When there is stress, P53 is stabilized and can accumulate in the cell. When there is no stress, P53 is very quickly degraded by its natural inhibitor called MDM2. So when there is stress, such as oncogene activation, hypoxia, or DNA damage, P53 accumulates and behaves as a transcription factor that can transactivate apoptotic factors, DNA repair factors, growth arrest factors, and can also inhibit angiogenesis. So this is for wild-type P53. Now, we know that P53 is very often mutated. Actually, P53 is the most frequently altered gene in human cancer and also in breast cancer. There are over 20,000, probably 25,000 different P53 mutations reported. And these P53 mutations are most often missense mutations. There are also some frameshift mutations and nonsense mutations. Most of these mutations are located on the DNA binding domain of the protein, and you can see that there are a few hotspots, many hotspots actually. Now, regarding breast cancer subtypes, P53 mutations are not distributed homogeneously in breast cancer. In luminal A tumors, P53 mutations are very rare, 17% probably. On the other side, basal-like tumors bear almost 90% P53 mutations. In luminal B tumors, 40%, in HER2 amplified tumors, 50%, and in molecular apocrine, those tumors that have estrogen receptor negative and androgen receptor positive, almost 70% cases are P53 mutated. And it is not only about prevalence that there is heterogeneity. Also, the mutation types are different among breast cancer subtypes. On the left panel, you can see that in luminal subtype breast cancer, there are many more substitutions, especially AT to GC1. On the right panel, you can see that truncating mutations, so mutations without protein or with a truncated protein, are much more frequent in basal-like tumors. And this is of importance because non-truncating mutations may account for new protein functions, while, of course, truncating mutations have low level of protein expression. Now, something that Dr. Ellis already told us a few minutes ago, apparently, among luminal tumors, inactivation of P53 by mutation or by amplification of the inhibitor, MDM2, is likely to be a causal event of the luminal B phenotype. In another subtype, the basal-like subtype and Claudin-low tumors that are very aggressive tumors, P53 is known to regulate the epithelial mesenchymal transition phenotype and stem cell properties through upregulation of this microRNA. So since in these tumors, P53 is very, very frequently mutated, in these tumors there is very often a release of the epithelial mesenchymal transition program with an increase of the mammary stem cells in these tumors. Also, it appears that the timing of P53 mutations depends on the breast cancer subtype. In this study, P53 mutations was the first important event in luminal tumors, but it occurred only after PTEN loss in basal-like tumors. Now, I would like to tell you about some not so new and also new findings regarding the possible impact of P53 about response to treatment and response to chemotherapy. We all knew this now a little old paradigm 20 years ago. The paradigm is still that in response to DNA damage, P53, when it is wild type, will preferentially induce apoptosis of the tumor cells and so should induce tumor response. And conversely, when P53 is mutated, there is no induction of apoptosis and no tumor response. So this is the paradigm. Of course, we all know that it is not true in the clinical practice. The facts actually are that in estrogen receptor positive breast carcinoma that are very often P53 wild type, well, usually there's a poorer response to chemotherapy compared to estrogen receptor negative breast carcinoma that are often P53 mutated. So one first level of variation of the P53 impact is the type of chemotherapy we use. 5-FU, for instance, in this paper, has been shown to induce preferentially apoptosis, while adriamycin has been shown to induce, with P53 wild type, cell cycle arrest. But this is, of course, much more complicated. And there has been so many publications trying to link P53 and response to different kinds of chemotherapy, many different results, but also many confounding factors. And after the talk of Professor Hayes, I can tell you that indeed it is very hard to say that a marker is a true biomarker, a true tumor biomarker. Because in all these studies, sometimes there has been a mix of different breast cancer subtypes, different molecular subtypes, but not only molecular subtypes, also sometimes inflammatory and non-inflammatory tumors. And this can be a problem since inflammatory tumors may have some biological specific properties. Also different endpoints, response, survival. Also different chemotherapy regimen, not only the drugs different, but also the doses. And I want to tell you after that the doses may be crucial in terms of induction of P53. And also, last but not the least, different methods that have been used for assessing P53 status. We all know that many studies have used immunohistochemistry as a method for assessing this status, and we all know that there is no good equivalence between P53 mutation and P53 accumulation. We have done in our institution in Paris, in Hospital Saint-Louis, a trial several years ago, and I will tell you that recently there have been some new data about that. So what is the story? We reported that in locally advanced non-inflammatory breast carcinoma, now look at the table on the lower, P53 mutant tumors had very frequently pathological complete response. You see over 50%. Response to what? To a dose-dense anthracycline cyclophosphamide treatment. Conversely, in P53 wild-type tumor, we never observed any pathological complete response. And this is not only about response, because in this new data, submitted data actually, we show that there is also a strong p53 effect. On the left panel, you can see that the p53 mutated curve is much better than the wild type one. So very good effect of mutation of p53 in dose-dense adriamycin cyclophosphamide treatment. But we could not show any effect in taxane-based chemotherapy. This effect probably comes through the dose of the alkylating agent, because in this report we compared 3 different regimens, epiribicin alone on the left, FAC on the middle, and dose-dense epiribicin cyclophosphamide on the right, and you can see that the pathological complete response rate is very high, only in the dose-dense regimen, with a very high dose of cyclophosphamide and also very dense. I mean, it's every 2 weeks chemotherapy. So we proposed already a few years ago this model linking p53 status and response to dose-dense chemotherapy. With, in response to anthracycline, on the left, p53 wild type would induce preferentially cell cycle arrest. And these tumor cells, arrested tumor cells, would of course resist the effect of high doses of cyclophosphamide, and after treatment is completed, would restart to proliferate, and there would be tumor progression. On the right part, conversely, when p53 is mutated, there would be no cell cycle arrest, no apoptosis, and probably accumulation of genetic abnormalities and mitotic catastrophe that would lead to pathological complete response. And there would be, on the right, lower right part, there would be still a few tumors, a few p53 mutated tumors that would escape and that have indeed a rapid progression. We have indeed already showed that there is induction of senescence in p53 wild-type tumors after high doses of anthracycline cyclophosphamide. And on the left part, you can see induction of SA-beta-galactosidase and p21 as a marker of senescence. And that's the new data. Last year, in 2012, another totally independent team reported experimental data that go exactly in the same way as our first report. This is this paper by Jackson and collaborators showing that wild-type p53 activity impairs doxorubicin response. And you can see in the 2 upper panels that in MMTV Wnt1 mammary tumors, there is early relapse of the proliferation. Even on the right upper panel, where there is one mutated allele, and the other allele is not mutated. And in this paper, the authors think that the second allele is totally determinant. If it is wild type, then the tumor will behave just like a wild type tumor. But on the lower panel, both alleles are mutated or lost, and you can see that the relapse can occur, but much later on the left, and do not occur on the right. And this effect comes again through induction of senescence in p53++ or p53 plus minus tumors. Also, an important thing when speaking about p53 is to take into account the estrogen receptor background, and another recent report clearly demonstrated that estrogen receptor can prevent p53-dependent apoptosis in breast cancer. So we could give some more details on the model. It is the same model, but you can see on the left that p53 wild type indeed induces cell cycle arrest and true senescence. And also, we know now why there is no apoptosis in these tumors, since they are often estrogen receptor positive that will prevent the induction of apoptosis. So there is clearly a need of a true clinical trial that would demonstrate that this dose-dense chemotherapy has a beneficial effect through p53 mutated. There has been recently a big trial with neoadjuvant taxanes compared to non-taxane chemotherapy in 2,000 patients with p53 assessment very well done with a functional test in yeast, but the authors could not show any p53 mutation effect. But in this study, the authors did not use high doses of cyclophosphamide. And we do think that there is now a need for a clinical trial that would use dose-dense anthracycline cyclophosphamide regimen in triple-negative tumors, certainly, maybe also in luminal B tumors. Of course, it would be a neoadjuvant trial in locally advanced tumors. Now, I want to conclude. We saw that p53 mutations types are definitely not randomly distributed among breast carcinoma, but they are clearly linked with molecular subtypes. Also, these types of mutations may have some biological effects very linked to the carcinoma subtypes. And there are now recent findings that shed new light on the impact of p53 status in response to dose-dense anthracycline cyclophosphamide treatment, and this should be, of course, validated with a randomized clinical trial. Thank you.